All right, welcome to Spine Conference, and we can start now because Paul's here. And where is he?
Okay.
Okay, all right, good. And today we're going to discuss a case of that I think is very interesting, and I think everyone's going to disagree with what I did. So because of that, that's why I want to show this case. So it's a real case, 84-year-old man. That's not him, but he looks similar to him. And his chief complaint when I saw him in 2016, so it's 3 years ago, was weakness of his hips and legs. He said, I'm weak in my lower extremities, hips and legs. He says his foot slaps, his left foot slaps. He is tingling in both lower extremities, and he cannot walk 3 miles a day. And why that's significant is he has done that almost his entire adult life. He walks 3 miles a day, which I think at the age of 84 is quite remarkable. And he has ataxia, he has difficulty walking. His past medical history: left iliac wing Paget's disease, both knees are replaced, bilateral carpal tunnel release, right carotid endarterectomy, atrial fibrillation, high cholesterol, and he has mild cervical stenosis. He's married. He's in a very good relationship at home. His wife's very helpful, and he is a retired Bethlehem steel worker. So you can imagine he was those guys I have found are very hardworking people. And this guy he wants to walk. He says, "Doctor, I'm weak and I want to walk." So anybody have any questions about so far? Just anybody can interrupt me if they have any questions whatsoever. Who can tell me the significance of a foot slap? What is a foot slap? Can anyone tell me what a foot slap is? All these smart people. Somebody.
Good, Jesse. What is it?
I guess definitely.
Well, let's say so weakness of dorsiflexion. So yeah, anterior tib. So when your heel strikes, your anterior tib fires. If your anterior tib doesn't fire, your foot slaps. So it's a relative weakness. So this is his pain diagram. I do pain diagrams on everyone who comes to the office, and it tells you something about the patient. And then the question is, at age 84, what's his life expectancy? If you look it up on the Medicare website, his life expectancy is 90. So he has 6 years to live, most likely on average. So here's his x-rays. Who can, what do you think of the, Dr. Samir, what do you think of the x-rays?
Well, there's multi-level degenerative disease, dextroscoliosis of the lumbar spine. You've got marginal osteophytes, intervertebral disc spaces are narrowed at multiple levels. The concavity of the scoliosis on the lateral view, you can see a little bit of antex-erotic changes. The AP distance on the lateral view is narrow, so there's canal stenosis, vacuum phenomena. Most severe narrowing is at L5S1 as far as intervertebral disc space. So it's pretty bad. It's
pretty diffuse, right? Every single level. Yeah, every single level. And flexion extension views, L4, L5, I thought had some spondylolisthesis there.
Yep.
You agree with that? Okay, but not gross, but spondylolisthesis. This is in December 2016. So how about the sagittal cut?
So yeah, so you got a sagittal T2 on the left and T1 on the right. You can see multi-level degenerative disc disease, and there's redundancy of the cardiac guana nerve roots. So 5-4, so above L3, L4, you get these areas of cardiac guana nerve roots that are buckling or redundant. So it tells you that below there's pretty severe stenosis. So 5-4, L3, L4, and L4, L5, you get pretty severe canal stenosis. And what's causing it? Large disc bulge, ligament thickening. It's what you can see on the sagittal view. So that's what I can tell you about.
Okay.
Based on those 2 images.
Oh, that's good. And kind of these are parasagittal cuts, kind of similar, I think, from what we said. So I'm going to. This is T12, and the spinal canal looks pretty normal, and you get an understanding of the size of the spinal canal normally for a patient. Now this is at the T12 L1 disc space, and this. The bottom article is from Spine 2010, and it's an article describing the severity of spinal stenosis based on the morphology of the thecal sac. So I thought this was interesting. There's different grades of stenosis that this person graded, and I thought this case was under the criteria rootlets are centrally located and occupy greater than 50% of the thecal sac. So if you look here, the rootlets are probably less than 50% with the spinal cord, but the rootlets make up a lot of the thecal sac, the area of the thecal sac. So this is just a way to grade stenosis. And anybody who's interested in this article, I'll send it to them. But you can see here that the rootlets are less than 50% of the thecal sac. This is at the L1 pedicle. So T12, L1, L1. What do you think of L1, L2, Dr. Samir?
So in this axial T2, you're seeing ligamental tendon thickening, and you do have some hypertrophic changes as well. And the other component that's contributing to canal stenosis is a disc bulge. And you can argue also that you may have some right lateral recess stenosis. So traversing nerve root of L2 may be a little bit constricted there.
Could be caught there, yeah. So if you go back to this article, this falls, I think, under the rootlets are still able to be individually identified, but they occupy almost the entire dural sac area, like very little CSF. So here's L3, it opens back up at the level of the pedicle. L2, L3, pretty similar, right? Not to beat a dead horse. 3, 4, I thought 3, 4 was worse, right? And then you cannot see the rootlets at all, and it's just a gray area. And very little posterior epidural fat. There's a tiny bit, but very little. 4 is normal. 4, 5, stenotic, would you agree? Mm-hmm. 5 is normal. And 5, 1 centrally I thought was open, but some lateral recess stenosis and foraminal stenosis. Mm-hmm. And this gives you an idea of the sacrum. So, problem list. This is an octogenarian. Stenosis from L1 to L5, L4, L5 spondylolisthesis, and he's weak and he wants to walk. So I want to ask the room, is this person not a surgical candidate? Too old? Too many disease levels? Or what's your just general thought? Anybody?
I think as long as you have a discussion with him about potential risks and complications, quality of life for this guy.
He wants to walk.
And yeah, quality of life. But clearly he's cleared by his primary care doctor. I think he's a candidate.
But he's not healthy. He has peripheral vascular disease, atrial fibrillation, carotid endarterectomy. So he's got medical problems. I mean, 6 years, at least 6 years to live probably, as long as he's healthy, maybe longer. So I see a lot of these people in the office, and I'm not sure what to do with them.
More and more.
Yeah. Yeah, in the next 10 years, more and more, and these people want to walk, they want to exercise. So anybody would not offer surgery?
We have any bone density data?
No. Well, how would that affect your thought process?
Well, let's say that he had came in with a bone density of T-score -3. Then you might say, I'm not going to instrument all these levels. Maybe you're going to go for an uninstrumented fusion, or maybe you're going to do bilateral laminotomies instead of placing any hardware. So that was what he did. The other thing to point out here, which is nice, is that he's not obese. I mean, he's got like 2 centimeters of subacute fat before he gets to the spinous process. So that'll also tilt me towards offering him an operation.
He's thin.
Yeah.
He's thin and he's very strong. He's a vibrant person. He's more like 60 than 84. And if somebody walks 3 miles a day, that tells you something. Okay, so we're going to get back to what surgery to do, but let's just go over spinal stenosis. I just want to do a quick review, and I hope I don't bore anybody. So Henk Verbiest, when I started my fellowship with Ron DeWald, the first question he asked me was, do you know who Henk Verbiest is? I said, I have no idea. Dr. Zorin didn't teach me that. So Henk Verbiest was a neurosurgeon, and he wrote an article about spinal stenosis, and his article, and anybody who wants this article, I'll email it to him, gave us the numbers 10 millimeters, 12 millimeters of relative and absolute stenosis. And this is a picture of my secretary with the cervical spine model. And if you look down the center of the spine, there's a spinal canal where the nerves run. And this is from Renee Louis' book showing the cross-sectional area of the spinal canal. It should be relatively uniform as you go down the spine. And just the ballpark figure, L4, L5 is the most common area for stenosis. The ballpark figure should be 23 millimeters transverse diameter and 15 millimeters AP diameter, just ballpark figures from anatomy. And tell me what's a normal anatomy, Dr. Samir?
Normal anatomy?
Yeah, on this view.
Well, so what's normal about it is you got a lumbar lordosis, you have normal vertebral body heights, discs on the sagittal T2 show the water within the nucleus pulposus, so it's dead right on T2, and you got the dark annulus fibrosis. I don't see any disc bulge, there's no disc herniation.
Yeah, so if you look down the posterior longitudinal ligament, that thing's a straight line.
Yeah.
Okay, that's good.
Looks normal.
Yeah, it looks normal, but some people don't know what normal is. But that's why I like to show normal. And the spinal canal, as you march down the spine, should be pretty uniform. This is just that someone had a far lateral disc herniation, but everything else was normal. And then back to this last article I told you again. In this case, the rootlets are dorsal and occupy less than 50% of the thecal sac. So that is sort of like a normal spinal canal. Cross-sectional area, many people use 100 millimeters or 75 square millimeters for stenosis. And see, it's completely symmetric as you go down the spinal canal. So who can tell me what resident can tell me what areas can be stenotic in the lumbar spine? Somebody.
So you have the central stenosis.
Mhm.
Now you can have lateral recess, pyramidal, and far lateral.
Okay. What causes central stenosis?
Central stenosis is a central disc herniation.
And hypertrophy of the ligament flavum and facets, it can all three of them come down for centrally. And what can give you lateral recess stenosis?
Lateral recess is usually facet hypertrophy or unilateral disc herniation.
Yeah, or ligament flavum and facets. How about foraminal stenosis? What can give you foraminal stenosis?
Foraminal stenosis is usually facet
Yeah,
hypertrophy.
the superior articular facet can do it. Maybe what else is there? What else? Look at the frame in there. What else is there? Right up below the pedicle, between the vertebral bodies. What else is there that can give you foraminal stenosis?
Yes. Huh?
Disc.
Yeah.
You can have.
What else? What's the third thing? Most common.
Sepsis.
What else?
But
A teenager who comes into you with back pain.
Pars.
Pars,
Yeah.
right? Right. So cervicals from the pars.
What else can cause stenosis? Broadly.
Listhesis.
Okay, what else?
Any sort of occupying lesion, epidural abscess,
Epidural
tumor,
abscess.
tumor,
Tumor.
intraocular,
Blood.
definitely blood.
Cyst. Right. Fat.
Deformity. Especially on the concavity of the curve.
Any deformity, yeah, let's see.
What's it called, Brian, if there's fat causing stenosis?
I just know that like the epidural lichomatosis, like
So pretty much anything you can think of can cause it, almost anywhere.
Okay, so ligament flavum is a common cause of stenosis, and this just gives you. This is from an article in Skeletal Radiology, just describing all the things and the patterns of stenosis. I thought this was kind of helpful, looking on the left of the cartoon. Of the disc bulging backwards, the facets being hypertrophic, the ligament flavum being hypertrophic, the crowding of the nerve roots. And ways to describe it are CSF around the roots, are the roots separated, no space between the roots, epidural fat. As far as the foramen, is there perineural fat, cross-sectional areas, short pedicles, interlaminar angles? All these factors go into what causes stenosis. So anybody who wants this article, I can email it to them. So as far as the foramen, we talked about this. So that pen is right in the foramen, and the height can decrease it, foraminal disc protrusions, hypertrophy of the superior articulating facet. And as the surgeons, how do you guys decompress the foramen? I have my opinion. I've changed my opinion, but I always go from inferior because I feel if I have to get to the foramen, I feel that it's a superior articulating process of the facet, the one lower, that's the biggest offending lesion. So if you look at that where my arrow is, that's the guy that I think I have to cut out. What do you guys think?
If there's a spondylo, sometimes it's
No spondylo or pars fracture, because that's kind of like a different.
Okay, then normally it is the superior articulating process, that's right over the frame. So the question is whether you have superior inferior impingement or anterior, posterior, ventral, dorsal. That's what you have to determine.
From the disc.
On the anatomy.
Okay.
You have to compress depending on where the tissue is coming from.
Okay, so just another, what's the normal frame in 3 millimeters or 15 millimeters height? So history, who can tell me, Brian, what are things in history for spinal stenosis? What do people say?
So you got one of the pictures up there. They have the shopping cart sign is the traditional one where they have a lot of pain, they'll have a lot of pain with walking, pain down the legs, with walking and extension activities, walking downhill as opposed to uphill. And you say like when you go to the grocery store, you get a shopping cart. These people just cruise through the aisles.
Mm-hmm.
Low back pain, sciatica, yeah.
What relieves the pain?
Rest or flexion activities.
Flexion and rest, like sitting down or stop standing.
Mm-hmm.
Stop walking. So, and bicycling, can these people bicycle?
Yeah. Should be.
Spinal stenosis should be able. So ways to measure it is ODI, spinal stenosis, Swiss, and SF36. Why do people have pain with extension with stenosis? Anybody know? Why does it hurt worse? Can anybody tell me?
So if you have a lot of hypertrophy of the posterior elements, extension might sort of lead to the worsening of the stenosis posteriorly if you're kind of squishing and then compressing the cord from posterior.
Yeah, so the ligament of flavum buckles. So look at this CT myelogram. On the left is flexion, on the right is extension. See at L4, L5, the spinal canal gets tight. And the reason is this cartoon shows you the ligament flavum buckles. So when you extend, when you flex on the right, the ligament flavum is taut, and when you extend, the ligament flavum buckles. And that's why you get that stenosis that you see here on the myelogram. Okay, and how can you differentiate vascular stenosis from neurogenic stenosis?
Can you go back on the slide? This is a great image. There's something called the apple core sign. The apple core sign in the myelogram. Maybe Carl will understand that term. But that makes sense when you look at that, right? So when it buckles in, you get that hourglass configuration on the myelogram or an MRI scan. It's helpful to point that out to patients. They can understand the image much more than you describe it.
Can we still do myelograms? That's that people send people for myelograms all the time. So how do you differentiate vascular from neurogenic?
Vascular is usually really after a certain period of time. It has a certain onset after it's walking a certain amount of blocks. So say I can walk a block before my legs start to feel heavy and cramping. And then the rest is usually a couple of minutes.
How is that different than neurogenic claudication? Very important difference. You know, what you said, walk a block. What's the difference on a patient that neurogenic claudication versus vascular as far as their consistency in the distance they can walk? Is there a difference?
I think it's like the same distance for neurogenic versus vascular. Other way around.
Just vascular is consistent. At a block every time.
Yeah.
Neurogenic, sometimes I can walk, 3 blocks, 4 blocks, other days a block. So it's inconsistent. It's different with neurogenic. That's important. Vascular is consistent every time.
Yeah. Anybody else want to add? I can keep going, but does anybody else want to? I mean, if you live with someone with stenosis like my dad, you learn all the signs. Like when he goes to the grocery store, he goes, "I need a chair. I need to sit down." And when they sit down, it gets better. Vascular people can just stop. So fast people say, "Hold on, give me a second," and they just stop walking. They're standing, and they get better. And then they start walking again, and the pain recurs. So if people say, that's another thing. If people just say, "I have to sit," it's usually lumbar stenosis.
Bend forward.
Yeah, or bend forwards, shopping cart. And the other thing is just pulses. If someone has a good pulse, it's not vascular. So treatment is rest, medications. That's Paul's doing on the left in residency. It's like steroids, ibuprofens, nonsteroidals, muscle relaxers, amitriptyline, gabapentin, Valium, pain medicines. Does anybody else do anything for stenosis just to get them over the hump, non-operative treatments? So nonsteroidals come with some risks: gastrointestinal bleed, renal failure, high blood pressure, cardiac risk factors. And then if people are on anticoagulants, you can't use it. Physical therapy, core strengthening is a non-operative option. Epidural steroid injections or epidural spinal injections in general are an option. So surgical treatments are full laminectomy, where you fully open the spinal canal. And then there are other options like porthole technique or unilateral laminectomy, bilateral decompression, where you decompress the spinal canal from an ipsilateral approach. And I learned about this from Chuck Edwards. He used to call it porthole technique. And we would open up the spine and just do laminar foraminotomy both sides at the level of the facet and the discs, which is where the stenosis is. And it was published by Kleeman in 2000. But since then, there's been, actually before that, there's been many articles in the neurosurgery literature about ULBD. And you can see on the right, the stenosis. On the left is how you can open it from just a one-sided view. And this is just a review 2006 from Germany. This is the first article I read about ULBD from Germany. Has good results. And this, Ralph Mubbs from Australia wrote a big review in 2014. So how do you do it? This is how you do it. And stop me if you have any questions. You need a working window, and you go down the posterior spinous process down the lamina to make yourself a window so you can see. You're doing this through a hole, and you use wax. Once you get down to the lamina, you have to basically outline where you're going to do the decompression. So the dura, if you look at Rene Louis' article, is 23 millimeters at L4. So you need 11 millimeters from the midline. So it's 3 millimeters for a burr. So you need 3 burrs, basically. And you have to keep the pars intact. So you have to know where your pars is. So I make the first cut with 3 burr holes. And I try to go above the ligamentum flavum. I know where the ligamentum flavum is just from experience. And then I connect the two. I connect from where I cut the posterior spinous process and where I made my first cut, I connect the 2 areas. So you can see here, at this point, you're down to the ligamentum flavum, and you have a working window. You see the channel. And I think you have to keep the ligamentum flavum on as long as possible because it protects you. So at the very top, and you can do this different ways. This is how I do it. I find the dura, I remove all the bone first, and I keep the ligament intact. And then so you should be looking at entire yellow ligament at this point. So here's the yellow ligaments on, and then you lift the ligament and remove that easily with the kerrison. And then I think this is a key point. The lateral recess you have to get with a curved curette because you can't see it very well because you're on the ipsilateral side. So you have the dura exposed, and then you tilt the table and you look to the opposite side. You undermine the posterior spinous process, and that white thing is the sucker. So the sucker I use a malleable sucker, so it can bend, and it protects your dura. So you're pushing while burring with the sucker, going now to the opposite side. You see the ligament there. And this is the suction tips I use, just the plastic vascular suction tips. So pitfalls are restenosis. I've had many cases where the opposite side, the contralateral side, becomes stenotic. You can get a dural tear. I don't think it's any more than regular decompression. Nerve injury, instability. You can fracture the facet. You can fracture the pars. You can have an inadequate decompression. Or the framing is very difficult to decompress. But my opinion is if you really want to decompress framing well, you have to do a fusion. That's my opinion. So it's from the prone position. This is the Andrews table that was real difficult. It was a real futz to work with. We did that in fellowship. And then this is the first Jackson, and this is the second Jackson. And you can see that the second Jackson has the cup. I don't get to use the new Jackson because only Dr. Tortolani can use the new Jackson table. So that's me on the table. You see the arrow? That C cups your chest. So it's really good for big fat people like me. You see how it cups me? And you can turn it. And I just use a microscope. This is how the microscope works. And the high-speed, this is not the high-speed drill that I use, but this is the drill bit I use. It's 3 millimeters. This is the Ansbach. So note the thickness of the cable, and this is with air, compressed air. Now I use the Medtronic because I use it mostly because look at the wire. The wire is like a feather. So it's just a lot easier to use. It's not heavy on your hand, and you can pass it back and forth to your assistant, no problem. And it's also not as loud. So that's why I use the new one. Okay, so let's back to our case. What do you guys want to do for this case? Anybody, any surgeon or resident what do you want to do? So L1, L5 stenosis, L4, 5 spondylolisthesis. What do you guys want to do?
Why are you thinking about that, David? Who do you think does better, old people or younger people? Over 65 or younger 65? When you're looking at symptoms of stenosis.
I think old people probably do better.
Why? Everybody agree, their consensus? Over 65 do better? As well as your disability improvement, patient reported outcomes. What do you think, Jess?
I can't remember why, but I think that's right too. I think that older patients just are happier with any gains they get with the movement for so long.
What do you think? That's true.
I would think lower demand. They want to do like their threshold for success could probably be lower, and they have longer life expectancy, so lower chance of recurrence.
They have a higher life expectancy than someone younger than 65.
Like years left.
Yeah. They have less time to
No, that's what I said. They have less time left, so they have less time to recur.
Okay. Who has a higher complication risk? Older or younger?
I think older because of medical comorbidities.
So how can you reconcile that? Older patients have more complications but do better.
Is there initial disability more severe?
That's the issue. So most of our outcomes look at delta and disability, right? So the older patients come to surgery worse off, like this patient probably can't walk a block, right? And they're stoic, and they've been living with it for years, and they've been living it for so long, and now they have AFib and CHF, and all their friends have had surgery and they're worse, so they don't want to have anything done, but they're miserable. And younger patients, often the younger group, don't have the symptoms quite as bad. So when they get their improvement, they're better, but they don't have that same change in quality of life. And the older patients, the complications that they get are recoverable after 6 weeks or so. Urinary tract infection, pneumonia, bronchitis, fall and they hurt their shoulder, all the different things. Now, stroke, like in this patient, AFib, they're going to have to come off their anticoagulants. That may not be recoverable, and we've all had those disasters. Heart attack, that's a tough one to recover from. But if you get through the lion's share of the complications, the older patients do better. So it's not a great reason to tell them they can't do it, but it does need to be weighed into the discussion. One of the hardest things, and we've talked about this at conference before, someone who's on AFib with a stroke risk, who's on anticoagulants, there's no consensus on when to restart their anticoagulants. I don't know.
There is a new procedure, right? They talked about is that the Watchman, where the cardiologist can now put in the atrial appendage a device that gets epithelialized that eliminates that problem of a blood clot in the atrium. So that is something to consider.
Is it temporary or permanent?
No, it's permanent. It's permanent. It's a new device called the Watchman. Look it up. I never knew about it until about a month ago. And they actually do it through a catheter. They put it into the atrial appendage. It's like an umbrella, and it epithelializes and encloses that hole where they get the clot, which then, and eliminates that. They come off anticoagulants, and it's done. They're done with it.
Who gets a Watchman?
Right now they're doing it on patients who have difficulty with anticoagulants. They can't be anticoagulated, can't be controlled, but for somebody like this,
people who need surgery, that'd be nice.
Yeah, but it is an option now.
They can come off right away. My grandpa got one. He was having recurrent leg bleeds, and he was able to stop anticoagulation a few days after the Watchman.
When you start it back up, I mean, I wanted to be
It takes
nice.
about 3 months to epithelialize the actual closeout to epithelialize, they said. So probably about 3 months before you can stop all anticoagulants.
Let's say you do let's do a poll, L1 to L5 decompression, L4-5 fusion. When do you restart the Coumadin or the whatever, Xarelto, whatever?
I've had patients that 7 days developed an enormous hematoma. So I like to, in the days when they're using warfarin, I'd start on day 7. So by day 10, they were fully anticoagulated.
Everyone do day 7?
But I know that some people are doing, I do keep a patient, there was an article about keeping a person on baby aspirin. There's no increased chance of bleed. So I will keep them on 81 milligrams of aspirin.
Aspirin, and then the larger one.
And then start the
a week
anticoagulation later on.
Yeah, because I've had a massive bleed at like post-op day 5 when I
Yeah,
really started.
that'd be really something.
Yeah.
That's a major concern when you have a big open canal.
Yeah. Okay,
Yeah, any thoughts on that?
I'll usually start in 5 days post-op.
5 days.
We do Coumadin where it takes a couple of days, or you start Xarelto. They sometimes will start them right on something that's right.
How about Xarelto? What would you start Xarelto? I use a week. I don't know.
I go much sooner.
When do you start?
I'll often do 3 or 4 days.
On Xarelto, full dose or prophylactic dose or what?
Full dose, yeah.
Do you have any bleeds?
I had a guy recently took that for post-op treatment, so he was on the case we looked at. This guy with non-PG risk and DVT, so I was a little bit more aggressive. I've had 2 patients in 15 years who've had horrible post-op strokes in the first week after surgery. So I don't know. Like I said, there's no consensus.
I've had patients with MIs and strokes, but I also had one guy who went to the nursing home after decompression, and I wanted to be nice to the cardiologist. I started Xarelto day 3, and he came back with a huge bleed with neurological injury and loss of most of his low extremity function. And I took him back, but because he was in a nursing home, it wasn't diagnosed. And a lot of these people go to nursing homes post-op for recovery. Yeah. All right. So this is what I did. I did a ULBD 4 levels, and I did an ipsilateral BMP non-instrumented fusion. So basically decompressed every single level, just approaching the spine from one side, and I put BMP in the lateral gutter at L405 from the spondylolisthesis. The case took an hour and a half, and here's what it looked like. So I'm done the entire case now, and this is it with the microscope. And here's in the posterior lateral gutter. I make the BMP and the mastergraph look like an ice cream sandwich, and I've decorticated the facet and the transverse processes, and I'm filling the posterior lateral gutter with BMP. So my thoughts are, this patient has spondylolisthesis, and when I've had failures, I have failure at spondylolisthesis levels with the decompressions. So I don't want him to fail the surgery. So I just put that, no instrumentation. So that decorticating and putting in that BMP takes 5 minutes or maybe 10 minutes at most, just to expose it and decorticate. And I'll show you here the decompression, because I know Paul doesn't believe me that I decompressed it adequately. 1 second, it's just going a little slow. That's another piece of BMP. But I took a picture of this because I knew Paul wasn't going to believe me. So you see the portholes, and you'll see it better in 1 second. I get a little deeper. But he has 4, I don't know why it's so slow, 4 laminar foraminotomies. And I think once you get good at this technique, it's faster than a full laminectomy, because you
How long did you do this?
This case took me an hour and a half, 1.5 hours. And I'm very honest about my time, because I want to know how fast. I want to know how fast I am with these cases. I'm honest with myself. You can see here the dura is fully decompressed, and all 3 levels are decompressed. But there's a learning curve, obviously. So your first 20 cases are going to be slower.
Well, it's a philosophical question. I think stenosis is a clinical or a radiographic diagnosis?
Clinical. Now that we've got a non-ionizing radiation to look at people for the last 20 years, we've learned that there's a decade by decade progression that we can just count on with the pictures are going to look like, not only in the spine, but elsewhere in the body. So certainly there are plenty of people on whom we get an MRI for other reasons. They have terrible stenosis, but they're not very symptomatic from it. So it's a clinical diagnosis.
Yeah, it's tough for us because nowadays patients get all their reports. And so you'll look at their face sheet, and the chief complaint will be, I have spinal stenosis and herniated discs. Right? And almost like asking for surgery because they have this in their report. And I think how we call this, how we describe it is really important, because I agree. I think it's a clinical diagnosis when it gets to the point that Spiro made about normal. So he showed an image of a young MRI scan, young patient's MRI scan as normal, right? But what's normal in a 55-year-old? What would a normal MRI scan look like in a 55-year-old? What do you think, Tyler?
It's going to be variable. You could expect some disc desiccation, some spondylosis, or it could be normal.
It couldn't be normal. I think that's what you're getting at. We look at scans by the years, and nobody in their 50s has a normal MRI. Everybody has disc desiccation. Everybody has disc bulge. Everybody has a set hypertrophy.
So if you take 100 asymptomatic volunteers off the street, right, and you get an MRI scan on their spine, and then you give it to a radiologist who has no information about the patient whatsoever, and the patients are over the age of 50, how many of those patients, what percent will have disc herniations that's read out by a radiologist?
It's 30%.
Over 50%.
This was studied here. I just happen to have a slide for you guys. I wasn't going to show it. But you guys are referring to Bowden's article 90 of, normal people never had back pain in their lives, greater than 40 years old. I used to think that was old. Now I don't think that's old. But there's also a cohort 40 to 60, above 60. But almost everybody has an abnormality. And then above 60, it's even more. I think it's like 50%, 50 to 60.
Yeah, so that I think is a key slide. So how well do you think the MRI imaging correlates with someone's symptoms? How well does it correlate? What do you think, Brian?
What do you mean when you say how well? Are you saying so you...
Someone has read out by radiology critical canal stenosis at L4-5. Like Spiro showed, that case that he just did, L3-4, critical narrowing, you would describe that. How well does that correlate to someone's symptoms?
It doesn't necessarily correlate.
It doesn't at all. Zero correlation. Severity of MRI and severity of symptoms have zero correlation. We see patients like that all the time. They come in and they're like, I look fine. I feel fine. No symptoms. I can walk 5 miles, right? So I think our definition of normal has to be age determined, age corrected. So I tell patients all the time, they come in like this, you have a normal spine for your age.
So a lot of times when I'm reading these MRs of the spine, I don't look at the history first. I just look at and then I give my report, then I look at what the provided history is. And I can tell you many times I'm disappointed because I talk about the right side, but then the patient's complaining about the left side.
Sometimes you guys don't get the history right. You don't get the history correctly because the tech doesn't put it in right.
This is important. I'll tell you that MRI started at the early 80s, okay, trained in 87, all right? The art of medicine now is determining what radiographic findings that you see are significant clinically. And that's why, when you're in my clinic, it's important to take a history, get a differential based on the history, and 90% of the time, you should be able to predict what the patient's MRI is going to show. And then when you look at your diagnostic studies, that confirms your clinical impression. The worst thing to do is look at the MRI first, because that changes and prejudices you in your evaluation of that patient, okay? That's the better way to do it. Now, for you, Samir, I would say you should do just the opposite, because if we say right L5 radiculopathy or right-sided symptoms, I think the question, we're giving you the clinical information, you need to help us and say, really look at what's going on the right side. So I think I would suggest to the radiologist, look at that clinical data when it's available, so that, because sometimes there's a far lateral disc herniation that can be missed very frequently, and unless you're thinking right side, that can be missed on the report. So, but for the residents, that's the art of medicine now. You should know what this patient has. You examine them. If they have clinically an L5 radiculopathy and their stories an L5 radiculopathy and it hurts when you lean to the right, you're thinking foraminal stenosis, Could be a spondylo. Is it, you know, that's the way you should look at this, because our imaging is so exquisitely sensitive that, you know, you can operate anybody if you just pick up that MRI and say, oh, you got this abnormality. A lot of docs do that, and they miss the diagnosis, and the patient is not happy. The other thing about this, I like to ask Justin, and what would you have done in this patient in your hands?
Yeah, I was going to ask the residents the same question, how to evaluate what to do. I wasn't here when what the symptoms actually were. If it's just purely neurogenic claudication, and it didn't conform to a specific radicular pattern, and then you just left with this trying to decide what levels. I think the first question is what levels, so definitely 3, 4, and 4, 5. 2, 3 is a harder choice, you know, looking at the cross-sectional MRI. But I would, if he didn't move on Flex X with facets that large, 81 years old, then I wouldn't have done a fusion. You know, just did a bilateral decompression, the Edwards technique that
Porthole.
That Spiro described. I feel more comfortable, especially these older patients. Their spinous process is so wide side to side that sometimes it's like touching the facet. So
and this guy
you wouldn't
had a congenital narrow.
You wouldn't decompress 2, 3
compared to the midline. He had kind of a congenital narrow. So I kind of
this guy. Yeah, this guy definitely had a congenital narrow.
3, 4.
It's not that. Wait a minute, 4 is big.
Versus, look how much room you have for lamina. I think he's congenitally narrow.
Here's the sagittal.
Yeah, so looking at that, I'm probably
just looking at the distance from here to here. That is a narrow distance compared to what we normally see, I think.
So what would you have done in this case? I want to show you a post-op MRI and a post-op CT.
Okay.
So I think
I personally
2, 3, 3,
I've
4,
personally done a complete L3, L4 lam. I'd want to do one operation for this guy. I want to make sure I get out as far as I need to for the lateral gutters and the foramina, midline incision, and I would not have fused this guy. I think he's got kind of auto-fused discs.
Just laminectomy?
I would have just laminated this guy.
L3, L4 laminectomy.
L3 and L4, so I would have gotten from L2
L2 to
L5. I would have decompressed that whole section. That's what I would have done in my hands.
Well, let me show you what happened. Because this is an interesting case because I have what happened. And you can see him walk. That's why I wanted to show this case. Because I knew it was controversial and nobody would have done what I would have done. So here post-op he came back, he says, I have low back pain when I walk. I was like, oh man, what's wrong now? So here's a sagittal. 5-1 looked normal pre-op. I mean, I thought 4-5 wasn't too bad. CSF about the nerve roots. He was not complaining of sciatica. He was not complaining of lower extremity weakness, just low back pain. I thought 3-4 wasn't bad either. 2-3 I thought looked really good. I thought 1-2 looked not bad. 12-1 I didn't decompress. So I got an MRI of his hip because he was having hip weakness, and he had a medial tear of his gluteus medius. So he called my office for, and I said to him, look, your low back pain is from degenerative disc disease, and I really don't think there's a surgery that's good for you. So he called my office for the medical records, and I was like, why? Just come in. I want to see you, because he called my records for another reason, because he wanted to do CBD oil. So I brought him in just to look at him one more time and to make sure I'm not missing something in him. So here he is now, 2 years, 2 months out, and his chief complaint is low back pain after he walks a mile.
Can you do that just
so,
one more time?
I mean, that's pretty good. I mean, and here's his gait, and he loves to walk. So does anybody want to describe the gait so I don't do it? What do you guys think?
Ryan, what's the gait like?
You can see you got Henk down on the side. He's got a Trendelenburg gait, so he kind of lurches to his right side as he's walking.
Okay, so the right hip, has a tear of the gluteus medius. So what happens when the foot hits the ground on the right? He's got a tear on the right hip. His right hip.
He can't abduct his pelvis, so it rises, and to counteract that, he has to lean towards that.
He's not leaning. He doesn't lean though. So some people lean, some people don't. So what happens is the right hip's weak. When your right foot hits the ground, the left hip goes down. So so you have to see it his backside. So we're just going to talk about. You can see the cartoon. So right, see how the left butt goes down when he steps on his right foot? That's because he doesn't have the strength to hold his hip up. So the cartoon shows you exactly, why it is. But how about his foot? How about his left foot?
Okay, can you do that just one more time?
He's swinging his left leg out, and he's got probably the weakest in his left.
Circumduction, yeah. So he has a circumduction gait on the left, and he has a foot slap on the left. So it's a double whammy for this guy, unfortunately, because his right hip is weak, which making his left pelvis go down, and his left foot is weak from L5 radiculopathy, so he has to do circumduction, and he has a foot slap. So it's unfortunate. He has his hip tear, and he's got this weakness of L5 nerve root. But really, at 87, the guy is, just remarkable. He just has low back pain. So anybody want to make any comments?
Developed the weakness, the L5 weakness late?
He had that pre-op.
Oh, okay.
So it never really got better. His L5 radiculopathy. And he developed the tear in his hip.
Yeah.
Okay, so I thought this was a good example of a gait abnormality, foot slap, circumductions, because the L5 nerve root also goes to your hip abductors. L5 nerve root lifts your ankle up, so it's just a good example. So I know Paul Zerian will not believe me that the fusion worked. So that's why I got a CAT scan. And you can see here on the left, the posterolateral gutter, just a remarkable fusion mass.
Why didn't the right work?
I didn't put one in the right. Remember, it's ipsilateral. Ipsilateral. And you see here in the gutter, just a solid fusion. See,
BMP and master?
5.6 cc's of BMP, medium infused master graft. By just decorticating and putting it in the gutter. So ipsilateral approach.
No local bone.
No local bone, no. I thought that was it's a remarkable case, and after cases like this, I was like, why should I ever use screws? What do you think?
If you have a disc that's that auto-fused, it's certainly probably safe. But if you had a big, juicy disc and you had a mobile spondylo, you wouldn't do that.
That's a different patient.
Right. In a patient like this where you have kind of an auto-fused disc and you just kind of want to be safe because you're worried about destabilizing it, I think it's reasonable to do in situ for an older person. I'll do that now sometime.
Any medical issues post-op? Because he said he was sick.
No, he flew. Yeah, he did great. It was a small operation, and it's only one side of the spine, so the dissection is limited.
Yeah. I think.
He still complains, mind you. The
How
patient.
far along were you in practice when you started doing that technique? Like how many years post-training?
Post-residency?
Yeah.
I started doing it a lot. The first time I did it was by accident. So I was doing it, I was like depressed. I was like, man, where am I? And then I look, I was like, oh, I'm on the opposite side of the spinal canal. I was like, whoa, I can do this from one side. So then I just kept doing it more. I was like 03, 04. And then I've been doing a lot of them since like 09, 10.
So my point to the residents is that, what you learn in your residency is important, but things continue to evolve forever. And so you have to be willing to bob and weave and have an open mind to other techniques. And bottom line is you can get things done. There's more than one way to skin a cat. But you got to make sure you're trained and you do it safely and you do it really well. I remember when I finished my fellowship, the last day of my fellowship, my mentor sat me down. He said, Justin, good job. You're excited. Yeah. What's your greatest fear? And my greatest fear was that I was going to see something that I didn't know how to handle. And he started laughing. And I was like, why are you laughing at me? And his response was, well, that's going to happen at least once in your first day. His point was, look, you do your fellowship so that you can understand and have an open mind and you're equipped to handle things that come at you, even if you haven't seen it before. So I think for Spiro to be able to be 10 years out and then be open to maybe doing something a little bit differently. And it can be serendipitous. It's not always like you're planning it. It just works out that way. You develop a whole new technique for doing it. So keep an open mind.
It's also nice to have partners because you learn from your partners. So when you're out on your own, it's more difficult.
And now that there are burrs now that I've seen for endoscopic for amyotomies where like the burr will be protected. It's almost like a arthroscopy shaver where you can burr, keeping the protected side against the dura and burr the lamina and the spinous process. But you haven't used that type of burr technique. You just protect the dura. That's my greatest fear. Is you get the burr.
I like the sucker. No, I like the sucker though, because the sucker sucks the blood too. And then you control both, and it's malleable. I like the fact that it's malleable. See, the problem I have with the protector is it's metal, it doesn't move. While the plastic, malleable plastic, is less likely to tear the dura or injure the nerve roots.
We use both. You know, I mean, I use a patty. I push a patty down with my sucker, and then my patty is protecting. You know, I don't use the burr in the midline. It's a technique that I've started doing on patients where I'm doing open procedures. I do a laminectomy and a diffusion at 4-5 and 3-4, showing some early stenosis. I will often go in and do that bilateral decompression at the 3-4 level and save the, posterior structure. So it was a way for me to get used to doing this technique in an open fashion, on a less stenotic patient, just the one where you get the early stenosis adjacent level. And the question is, you include it or not, a way to kind of maintain the stability, but just to get the hypertrophic ligament and flavum off, it's a good way to kind of learn to practice this technique. It is a nice technique for older people.
Yeah, the hard thing, I think, is that you're doing this on an extremely stenotic canal. And now, it's a 3 millimeter burr plus the sucker pushing down on the dura.
It's easy.
That to me is the nerve.
It's not as hard as you think. It's quite easy, because once you remove the ligament and flavum, you're decompressed. So you take that thing off in one big piece. After you burr a big hole, and now you just flavum there, and you leave it because the flavum protects you. And then you just scoop that whole thing off with a large curette, and you're decompressed. It's not so hard. I mean, it's just the idea. Once you get the idea in your brain,
it's getting to the lateral recess. If they truly have lateral recess and overhang, that's very severe. It's you got to push your dura way down in order to get
on the other side,
to get to the contralateral side.
On the other contralateral. Yeah, that's
the more difficult part. Not the midline. It's the lateral recess to get really decompressed, because that's where the root can be almost overhung by that overgrown facet. You got to push everything down to get in that corner to pull it up. Nice case.
Are you using a foraminotomy kerosene when you do that contralateral side?
Sometimes a curved kerosene. Yeah, I do. I don't use the burr up there. I just use the kerosene sometimes.
Any other comments or questions before we wrap up? All right. Thanks for coming.
Yeah.
Mm-hmm.